So, welcome everyone. Today we are with Dr. Enrico Robotti. It's a pleasure that we will be hosting him in India in November for the rhinoplasty course. Dr. Robotti has been the chief of the Department of Plastic Surgery of the Papa Giovanni Hospital in Bergamo, Italy from 97 to 2017. His current private practice exclusively focuses on rhinoseptoplasty with a specific interest in revision cases. He was the president of the Italian Society of Plastic Surgery in 2012-13. He's an associate professor in plastic surgery at the University of Rome and Milano and is an ISAPS International Visiting Professor. He's also the founding member and current past president of the Rhinoplasty Society of Europe. He's authored more than 700 presentations and papers and has been chairman, moderator, panelist, and an invited speaker at a large number of national and international meetings. He has ideated and refined several original techniques in primary and secondary rhinoplasty, which have been published in several journals. Over the last 15 years, he has organized and chaired the Bergamo Open Rhinoplasty course, one of the world's most renowned rhinoplasty meetings. So thank you so much, Dr. Robotti, for taking out some precious time to talk to us and, guide us a little more, not so much from the technical aspect, but to really kind of show us what your journey, your personal journey in rhinoplasty has been. So thank you so much for joining us, Dr.
It's a
Robotti.
pleasure. It's a pleasure.
Before we begin, I would really want to dive back right into the beginning of your rhinoplasty journey. You are a plastic surgeon by training. How did you choose rhinoplasty? Did it happen organically for you, or was it something you consciously chose, or did the career just gradually move in the direction of rhinoplasty?
Well, it's probably both because I was chief for 20 years, actually 21 years, after my training, which was first in the UK and then mostly in the US. And then I was both certified in plastic surgery and in general surgery. But when I had my department of plastic surgery, I got more and more interested in facial reconstruction and especially nose reconstruction. I had a big department. We were doing a lot of lower extremity. We were doing pressure sores, free flaps, and the general plastic surgery kind of things. But I got more and more focused. I think in nasal reconstruction, I really liked it. And then at some point, I wanted to put together a meeting just for nasal reconstruction. And then somebody else in the US had the same idea and said, and I saw an ad with the same kind of thoughts I had. And so I said, well, let's put a meeting together on rhinoplasty generically, including reconstruction. At that time, this was 2008, I think. There were not these huge numbers of meetings you see every week, especially in Turkey and other parts of the world. So I asked a few people. I became friend with Wolfgang Gubisch at the time, and the Bergamo meeting started. So from that time onwards, I started focusing gradually on the nose, and I also expanded my kind of understanding because I was plastic surgeon by birth and I knew I had a gap with the ENTs. I knew I did have a gap. So I tried to fill that gap as best as I could by getting acquainted and friends and courses, whatever, with ENT colleagues. I totally believe there should be no stupid competition. We should integrate. We have a kind of different approach. It's not so different now. It's becoming less different. But I wanted to understand the function. And so I needed to integrate that stuff. So I would say gradually I moved to rhinoplasty. It became more and more a focus. I think in 2015, probably, I started doing exclusively rhinoplasty. Actually, I think this was even a little bit before, maybe 2010 or something. And then I just focused completely. And it never bored me. Never bored me. It doesn't even bore me now. And the reason I think, I can get frankly I could get bored by doing breast augmentations, but not with rhinoplasty. It's fascinating. Every case is different. Customization is needed. And I think understanding how to customize is the most complicated thing. I see standardized rhinoplasties every single week in my practice. And some patients like them, some patients totally dislike them. And unfortunately, it's very common to just do a standard work that disrupts the beauty and the game.
Yeah, and I think you mentioned something very correctly, Dr. Robotti, that there are so many courses and so many conferences happening today. But back when you were a young rhinoplasty surgeon, I'm sure the avenues to learn were a little lesser than what I think most of us have today. What do you think in those early years? What were those things you were getting wrong? And really, as a young surgeon, because a lot of the surgeons who are coming for the course or trying to understand rhinoplasty, sometimes they get even anatomy wrong. They don't understand where it's coming from. So when you started or when you were young, what were those things that you were getting wrong? And you understand those principles differently over the years of experience.
Well, it's so the opportunities a young surgeon has today are huge. They can find literature everywhere easily. I had to make photocopies. I was talking with Nazim, who's one of my dearest friends. He had the same thing. He was in the US somewhere else, and he was photocopying all the time. I had tons of photocopies. Now just go to the web. Courses everywhere, dissection courses everywhere. So the opportunities for learning are extremely more advantageous. However, this comes at a cost. And the cost is not a financial one, the cost is the marketing. I totally believe marketing is excessive. I believe some people are driven by making things quick and easy and fast. And honestly, especially in preservation, which I adopt, but it has so many issues. And I see these issues every single day. They don't come only from Turkey, but many of them do come from Turkey. And honestly, maybe the drive for just making money quick and easy is one of the greatest problems I see with young surgeons nowadays. Which doesn't mean I have excellent people. I mean, some people who visited me or who did my fellowship, they are excellent. But some others are just driven by the money aspect. And then they shouldn't go to rhinoplasty, do something else.
It's true. I think the learning curve. I have a mentor, and Dr. Lokesh. They say that a rhinoplasty surgeon has to be a student their whole life.
Exactly. It's complicated. And people who just boast and do maybe 10 maneuvers in every nose or 20 maneuvers and then take half an hour by the clock, frankly, beware. Because if marketing is your aim, is one story, but if you want to do things right and have the right patient population, not only the 17-year-old with a little hump, that's not the way to go.
But if you look at the trends, barring whatever is popular today, when you started in, let's say, back in 2000s, what were those approaches like? How preservation is all the rage? People are naming different maneuvers. But back in the 2000s, what was really the concept or the principle which most of you were following? And you mentioned trying to get on board with ENT surgeons and plastic surgeons. So where do you think that gap was, or what were you doing differently then, which you've changed?
It was totally different, totally different. I was getting friends with Rod at the time, more or less, and we had this myth of US rhinoplasty, including some surgeons I got to know pretty well, like Barman, Ron Gruber, and Jack Gunter, and these kind of people. That was a clear, straight, structural rhinoplasty, which in some hands worked wonderfully well. So in a way, it was easy. It was not easy, but it was easy to understand. And once you understood it correctly, you could apply it. Then gradually, over the last 10 years, I mean, this, especially due to the term preservation and all the hype around it, it became incredibly complicated. And everybody wants to put his or her name on some technique. Some techniques are exactly the same as others, but they have different names. It's becoming a very confusing topic. And if somebody is young and wants to understand, it's very difficult. Although there has been a lot of progress. I do hybrid mostly all the time. I integrate some preservation with some structure and I mix instruments, and I have results which probably are definitely better than the ones I had at the time. But it's complicated. And one should separate facts from hype. which is difficult.
Yes.
Facts are facts, hype is hype.
I do agree. And I think getting people like you or Dr. Nazim or even Dr. Lokesh, I think one of the tenets of what you teach is, I think the structure needs to be preserved, whether you call it structural or preservation. I think at the end of the day, it has to be a stable osseo cartilaginous structure. So do you miss the
And
simpler times of when it was simpler to understand it? Do you miss that as well?
oh, no, no, no. I mean, as you say, one should be an eternal student. And in my opinion, if one does rhinoplasty, one cannot do breast one day, liposuction another day, and then something else.
Mm.
It's very, it has to be focused. It's too complicated. But what I would try to make people understand is that if you go to a course and teach and have somebody teach you something, you should trust that person to teach what is true. Unfortunately, it doesn't always happen. Because if somebody shows the best results, and maybe some of those results are even manipulated a little bit with different lighting or different flash or different zooming, and now worse than ever with AI, this is not going to teach you much. It's actually going to teach you wrong things. And I tell you, it's very difficult. So one of my advice, don't misinterpret me, is learn from somebody you can trust. And trust is difficult to place correctly.
Very rightly said. I think that is something which should be the foundation for anyone, whether we're starting off or even if we've done a few cases. I think the basics will remain the same, whether you name it something or you don't. I think I do agree with you there. There is a lot of confusion in rhinoplasty, and I think a focused approach, like you, I don't know, it's difficult for a lot of us youngsters where we want to do it all, and we probably fall into that trap of, okay, let me do a little this and a little that. But Dr. Robotti, you're not only known for rhinoplasty, you're actually known for the most complex and revision rhinoplasty cases. Sometimes when we look at your Instagram, we get scared that is this the field we want to go into with the kind of complications. So when you,
Well, well,
yeah,
let me just mention one thing before. I didn't want to interrupt you, but in a way, when I have my life surgery course here, the small one, I couple of times a year. But I always say, if you do a revision, even if it's complicated, your principles are easy. So that's not what do I do now? Do I do a full let down? Do I do a cartilaginous push down? Do I do a ballerina? Do I do a split? I mean, this is very complicated. But if you do a revision with rib, it's a matter of dexterity in your hands.
yes.
If you do have that, your principles are much easier. So even if you need the forehead flap at the same time or some septal reconstruction, even if that's complicated, the principles are purely structural, mostly structural. So in a way, conceptually, that's much easier.
So, Dr. Robotti, are you seeing more revision cases now than you were ever before? I mean, a lot of us have those
Uh,
discussions where
it's
revisions are coming to us.
it's difficult to say. You know, people have their own specific things. I probably am rather known for revisions, so I get revisions all the time. If I wanted, I could just abandon primaries because now my percentage is about 60% revision. I don't want more, otherwise I will stop doing primaries. So probably it depends. I don't say there's more revisions. Probably there have always been, but there is this big group of revisions coming from preservation. And this is just very bad. Honestly, if you stick a triangular pointy nose, for instance, over the last month of July, I operated mostly international patients, right? Now, two-thirds of these were people coming from certain countries which had no wish to be triangulated, made pointy with a low dorsum. They just didn't want that. And so they got it somehow. And if these people may look good in Sweden, they don't look good in Jordan or
Yes.
in Yemen. So I really am very annoyed by this because if somebody is a surgeon with ethics, he should not say just yes. and then do whatever he wants, but he should listen. So I know this may sound very old-fashioned, but I think surgeons should listen to what patients want. Otherwise, what patients say enters from the right ear and exits from the left ear, and then they get the same standard nose on everybody. And I tell you, this is a nightmare. I mean, some of these patients are just very, very, very depressed because they never wanted this.
Yes, I do agree. I think Dr. Nazim came last year, and we also had Dr. Nuri Çelik from Turkey. And they
Oh, he's a friend of mine. He's a lovely friend.
Yes, lovely person. And I think they couldn't reiterate enough the importance of the dorsum, the height of the dorsum, and, talking about how it separates the right and the left of your face. And if there's no dorsum, and I think, especially for like Indian context or even African Americans, where Indians are coming more for augmentation, they hate a low dorsum. So I think you made a very valid point. But that leads me to another question, Dr. Roboti. In India or in ethnic noses, we also have very broad noses. One of the most common complications in India we are seeing is alloplasty. Is that something you're encountering very sometimes, slip time nostrils? Is that also apart from the low dorsum that you're encountering in your revision cases?
You mean excessive aloplasty?
Alloplasty,
Well,
yes.
because it's usually stems from some textbook concept which somebody reads of leaving 5 or 6 millimeters, and if you do this in the nose with weak structure to begin with and thick skin, you will just collapse. So this stems really from some textbooks which state certain things which are not true in everybody.
So, what, if you would like to share with us, has there been a case which has stayed with you, which was your most complex case, which gave you nightmares whether this is going to, be successful, and you had.
Well, let me say it in two ways, probably not very much. I mean, I had a patient from the UK, a couple of years ago, lovely woman, by the way, and I get a lot of people from that part of the world, but she had had some Gore-Tex on her dorsum, and probably the blood supply had been weakened, so I lost a considerable portion of the columella, and that really bugged me. Because she's so lovely. We did several steps. She's pretty good now, but she's not good enough. But if I had some learning from patients, it's an old story. It's those patients who are few but exist who are really red flags and should not be operated. I made this mistake. I now seldom make it, but I still make it. And we all make it. This is the most difficult thing. If you encounter some patient who simply should not have surgery, and for some reason you don't identify that patient and you will do surgery, this is your annual nightmare. I get about one person a year, now maybe one every 2 years, but that slips through my criteria. And once you have these, I mean, you can't help them. It's impossible. And this is probably one of the most problematic portions of everybody's practice. People who say they don't have these patients, either they don't work enough or they just forget easily.
So, what would you say if that's something? I think when we're starting off, we're so excited to say yes to every patient because we just want to do more rhinoplasties. But what would your advice be?
Well,
Uh,
well, in a way, it's easier because those patients who have so high expectations and are so difficult, they won't usually come to you if you are a beginner. And as a beginner, you will probably deal with other patients who are probably better patients. So, in a way, it should not be terrible. However, if you feel you cannot help somebody because either you don't understand clearly what the patient wants, or you don't see what the patient wants, then just don't do it. If there's one advice, but I learned this the hard way, my consultations last about an hour, and that's damn long. But I don't understand people who take 10 minutes. It's impossible for me. Maybe 45 if I'm lucky, but usually it's an hour. And then I see them again for about 20 minutes for the morphine. So it's a long time. But maybe 10 years ago, I was showing a lot of my cases. But now I show very little and I want to listen because I want to understand who I have in front of me, if what the patient considers as a priority is reasonable and is feasible. So I listen much more now. I listen much more. And I make up my mind after listening. I don't have to show, tons of things.
And do you do a repeat consultation if you feel a little unsure of the patient, or is that no?
No, I always, no, I don't. Honestly, my time is not that much. My standard is this. I do one consultation, which takes a lot of time. I also see many international people. So, on those, I have a pre-screening because I send them forms. If I see they are just not, it's not possible, I will avoid them coming. Otherwise, they just waste too much time. But after my first consultation, I see people again for the morphine. I don't want to do the morphine on the same day and to see their CT scan. So my first consultation, maybe 45 minutes to an hour, more an hour. And my second is much shorter, about 20 minutes.
So let's talk about the Bergamo case, Bergamo course, Dr. Robotti. It's so popular. Most of us want to come for it. And I'm sure it started with the vision that you shared right in the beginning of teaching when there were hardly any rhinoplasty courses around. That's when I think Bergamo started. But over the years, uh, what do you feel are the basic principles of those courses that you change? And in like you mentioned, in a world where there's so much confusion, what is that core principle you stick by when you host these courses? And what is that endeavor? What do you want the takeaway for most of the students to be when they come?
Well, let me just be precise here. We had 7 editions and it went over about 14 years. The last course was 22. It was 4 days and a half. It was hundreds of videos, of panels, I mean, it was a huge thing. We had 600 people, 60 countries, and it took me a huge amount of time and effort to try and have tracks for beginners, for experienced, master classes. It was very, very complicated. My aim was to have people benefit from this course. So I was very strict even towards speakers. I didn't want them to just say whatever they wanted. I was leading them on a certain track. What they showed had to be a specific thing which I asked them to show. So that was the mini cases, the mini clips, and it was very articulated. Then what happened in a way, there were so many courses. Some of them took a lot of maybe inspiration from Bergamo, and some of them are excellent. So for the time being, I'm not doing the course. I'm just doing my own small life surgery courses. But when I was organizing Bergamo, my aim was simple. Who came there had to be clarified as much as possible and walk back home with real data and practical knowledge. This is why I was frankly rather fussy on the program and on the way it was articulated. It was very, 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 very complex, very complex. But one could find a specific track, and people were very happy about it. So maybe at some point we will redo it. We'll see.
Yes, I do hope we see one of your courses. And so you're a surgeon and a teacher. Do you think being a teacher has impacted the way you operate when you teach?
Definitely, definitely. I have an international fellow. I have 2 residents, and still I try to cut down on meetings because I don't want to travel every week. Otherwise, I don't really have time to think of my cases. But it definitely impacts because you have bright minds, you have good questions, you have good ideas. I pick things everywhere and then I elaborate them. One has to be humble to understand some changes. On the other hand, one doesn't have to embrace every 6 months. There's some colleagues who have a new idea even every 3 months. And I don't think that's the right way because if you do that, you'll end up in a hopeless confusion. So it's a mixture. It's a mixture. I think it's important. Teaching reflects on my practice, and listening to others reflects on my practice. However, it shouldn't be done just unconditionally to show something new every 3 months.
I agree. And I just want to ask you if you talked about so much, I think your times, which was simpler, but you did have a learning curve. Today, there's a lot of impatience in the generations before, where they want to learn things faster, like you said. And there's also too much information, which can be wrong for people. So if a student was to just question you, Dr. Robotti, what should my learning curve be like? How would you answer that question? How should they start? Let's say they're fresh out of ENT, fresh out of plastic surgery. We have so much information. What should really be our first steps into rhinoplasty?
Well, it's probably difficult. It should first be a commitment, meaning if somebody wants to do rhinoplasty, frankly, coming from wherever he wants to come, he should be ready to progressively focus exclusively or mostly on that topic. And then I would probably, if I were young, I would start on understanding structural rhinoplasty well. I would not do immediately the magic of preservation because believe me, I see terrible things. So I would not do that. I would start by structure. I would start by proper courses, dissection courses everywhere now. And then I would, once I am confident with open structure, because that's open, then I would still stay open and introduce concepts coming from hybrid or preservation. Then, if I were young, and this is a step I did not take, I could, and I'll tell you why I didn't take it. I could possibly consider doing something closed. I thought of that a lot. And my conclusion on which I have taken my decision now is that it's not worth it. But if I were 30-year-old, then maybe I would also try to do something closed without being that a brand in my practice, because then it won't work.
Great. I think we're almost at the end of the Q&A. It's been so interesting to know someone like you whose journey has been so profound. But what still keeps rhinoplasty exciting for you? Why is it such a passion? And how do you think that, after so many years, the way you're talking about it, you're still so excited and passionate about it?
Well, wait. I have always liked surgery. So the precise manipulation of human tissue, I did a lot of micro, a lot of little flaps, and even big flaps, whatever. I have always liked to manipulate tissues. And since I started as a reconstructive surgeon for many years, I also liked the pleasure of giving some patients form and function alike. So a nose is 4 centimeters, but in that 4 centimeters, I can still find nowadays a lot of excitement because I use my loops. I I have understood function and I analyze every case in great detail. So every case or most cases are different. So I don't get bored at all. If I did get bored, I would stop it. It doesn't matter. The money doesn't matter. I would just stop doing it. But I'm not bored at all. So it's technically challenging, mentally challenging, and I like the analysis, I like the execution. So I still enjoy it a lot.
Yes, and I think that shows in the way you speak
Yeah.
about it, or even the lectures that we've heard from you. Thank you so much, Dr. Robotti, for giving your time to us on a Sunday. And I think for people listening, I've seen over the courses that we've conducted, every time we got Dr. Nazim, Dr. Nouri, you, people who have more experience, I think there's this humility that reflects about your passion. And I think that is something that should be a takeaway for most of us, where the years that you have spent should be an inspiration for us to spend those years in rhinoplasty. Thank you so much, Dr. Robotti, for being with
It's
us.
been a pleasure. It's been a pleasure.
Forward to hosting you in India, and I hope you have a good time with us when you come here.
Absolutely. I'm sure I will. Have a great day.
Oh, bye.
Bye bye. Bye bye.